Welcome to T's Voices, telling the stories of the people in our NHS community.
Hello everyone and welcome back to the Allied Health Professional podcast. So today we have very special guests actually. We have a guest co-host, Kathryn Greer. Welcome to the podcast.
Thanks so much, Alison. Thanks for including me in your podcast. So I'm Kathryn Greer. I'm the Allied Health Professional Workforce Lead at North Tees, and I'm a physiotherapist by background. So we have Callum Pearce, who's the Interventional Radiology Manager at South Tees. Callum, I would love to understand all about interventional radiology. So I'll just maybe hand over to you just to introduce your team that's with you today and just to hear more about your role and the service that you provide to our patients.
Yeah, that's great. So, my name is Callum and I'm the manager for the Interventional Radiology Service. And I'm a diagnostic radiographer by profession, so still work clinically as well as managing the service. And with me today, I've got Bev Bartram, and she's going to introduce herself now.
I'm the senior sister in radiology nurses team.
And we've got Heidi.
I'm Heidi. I'm one of the staff nurses in the team.
So today we're going to talk about interventional radiology, which is kind of a lesser known area of radiology, really, because I think when people think of radiology, we think of X-ray, CT, MRI, ultrasound, all those bits and pieces. But what people we think about diagnostics and diagnosing people, but what people probably don't know so much is that we actually treat people in radiology as well. So the interventional part of interventional radiology is doing stuff about things. So we don't just figure out what's wrong with people and diagnose them. We can also treat as well at the same time. So we use X-ray imaging in order to guide us in order to do procedures. So we'll get patients in where we probably already know what's wrong with them and we have a pretty good idea of what we're going to do about it based on things like CT scans and MRI scans. And we'll plan interventions. So in order to do that, we have a multidisciplinary team. So we work really closely with other professions. So the radiographers, their aspect of it is very much with the imaging. So they're there to provide the imaging in order to guide us to where we need to be in order to do procedures. We have advanced practitioners, and they are both from the nursing team and from the radiographer team. And like myself, so I'm one, and we can do procedures ourselves. So we will work with the nursing team and we'll work with the other radiographers and we'll do procedures. So things like Hickman line insertions, nephrostomy drain changes, PICC line insertions, prostate biopsies. There's all kinds of things go on in across radiology that the advanced practitioners will lead on. And then we have our nursing team. And I'm going to let Bev talk a little bit more about what the nurses get up to in radiology and how they work really closely with the other professions.
So the nursing team in radiology is a very diverse role. We work as scrub nurses. It's not a specialist scrub nurse role, working with the consultant radiologists and radiographers. And we also have a small day unit where we care for patients pre and post procedure. No 2 days are ever the same. It's always a very busy service and it's a very nice team as well. We work very closely together and it's quite a specialist area. The nurses bring their own skill sets, as does the radiographers and the consultant radiologists. They all bring their own skill sets and we all learn from each other and share each other's knowledge and skills. And that's one of the things that I love about working there, teamwork and the diversity of the role. You have to be very adaptive. The nurses come in from different areas, not expecting it to be what it is, very specialised. We have a mentorship that takes about 4 to 6 months to learn the role in the theatres. Everybody really enjoys that. And there's also an on-call service as well that we have to become involved in once we've achieved our competencies.
Yeah, I just think it's really important to touch on communication skills. I think that's one of our key elements of working in the team because you're so multidisciplinary. You have to be able to communicate with everybody. And I think it's a nice place to be able to communicate with patients one-on-one. So you get the opportunity to guide a patient through their day in radiology, through their procedure. They may be a bit nervous. You can relieve their anxieties. So I think it's a really nice place to work and it's nice to be able to mix with the team and all add something different.
So from a patient point of view, when the patient goes in the room, so you're saying that because interventional radiology, that it's live imaging while the intervention's happening on that patient. So how does that work with the radiation safety?
Yeah, so from a radiation safety perspective, it is a high dose procedure. So when we look at the potential risk benefit for radiation dose, it's very much about the treatment of the patient. So we have some procedures. I mean, it does vary quite a lot. We have our kind of routine bread and butter work is things like angioplasties. So patients have got something blocked, probably in their peripheral system. So we're talking leg arteries usually. It's blocked. It's causing them rest pain. They've got claudication. It's really impacting their life, and it can be diabetic patients who have peripheral vascular disease, long-term smokers, things like that, but essentially patients who've got blocked arteries. So it really has an impact on their quality of life. They can't walk long distances. Sometimes it can be less than 100 meters before they can't walk, and the rest pain is the really important thing for intervention, because if they're not doing anything and it's hurting, then that is a real problem. So that's the point where we would intervene. So it tends to be that those procedures can last an hour, couple of hours. So it's a case of get them on the table, puncture the groin with a needle, pass the wire through to where we need to be, wires and catheters to the point of the blockage, and then we use X-ray dye, so contrast, and that can map out those vessels, and we can see where the blockage is. Other areas of the hospital do similar things. So if you think about the cath labs, where they do coronary intervention, patients might be having a STEMI heart attack, and we need to treat that. And that's the same thing. It's interventional radiology, but they are in the cath labs, and in this trust, that's separate. And then in neuro, they have the same thing. So radiographers working in the cath labs, radiographers working in neuroangio, those areas will do brain and heart specifically for their areas, and then we look after the everything else. So we're going to do the peripheral areas and we do the body. So essentially, if it's bleeding or blocked, we're going to treat it, and that's kind of our bread and butter work. So yeah, some of the procedures, for example, an EVAR, so an endovascular aneurysm repair. So the patient has an abdominal aortic aneurysm that is over the threshold to require treatment, and we've discovered it on CT or ultrasound. We will need to do something about it. So we put a stent inside their aorta. That procedure, depending on how complex it is, can be an hour or two, but if it's something really complicated and the aneurysm extends above the renal arteries or into the iliac arteries, we would need to do something called a fenestrated EVAR. So that's a FEVAR, and that is, to give it its full title, a fenestrated endovascular aneurysm repair, so FEVAR. And that can take all day. So we have to put multiple stents in. We have to identify the individual renal arteries and other arteries that might be involved as well, that would also get blocked by the stent, and stent them separately to maintain the blood supply to the vital organs and the bowel and the kidneys, as well as putting that stent in to occlude the aneurysm. So yeah, that can take all day. And when we think about radiation dose, that can be really, really high. And it's one of the areas, Alison, as I'm sure you know, in therapeutic radiography, it's one of the areas in the hospital where we can actually give patients immediate or short-term radiation issues, such as skin burns or localized hair loss. Normal diagnostic radiography is incredibly rare to give anyone those short-term problems of radiation dose. So if you're going for a CT scan, the risks we're talking about are usually those long-term risk of cancer. But in interventional radiology, we have that risk of long-term cancer as well, but we're also talking about those localized skin burns and potential hair loss. And we do occasionally hit the threshold to report those incidents. So it could be that at the end of the procedure, we calculate our radiation dose. We know how long the screening time was, and it did hit the threshold to report and to follow up the patient for potential skin burns and hair loss. Fortunately, we've never had any reported back to us that have actually had hair loss or skin burns. However, probably once a month, we might have a really big complex case where we do need to follow up those patients for those radiation issues. So radiation dose is something we think about all the time with patients, but also staff. So obviously we're working in those rooms. We're using live radiation imaging. We can't escape from that. We can't go behind a LED screen because we're doing procedures. We're scrubbed. We're wearing, it's more akin to surgery really than you would expect in radiology. You know, everyone is scrubbed in for a full surgical procedure. So we're having to wear lead aprons, thyroid shields. And for those of us who are right by the patients and actually doing things, and for our nursing team, they're also having to wear lead glasses, and we use dose monitoring as well. So obviously, as all radiographers, we wear our TLD dose monitor to monitor our radiation dose on a monthly basis or bi-monthly basis. But because it's a high dose procedure, we also need to monitor our eye doses. So we wear eye dose monitoring as well to check that the radiation dose we're receiving on a day-to-day basis isn't exceeding the limits where we might cause ourselves issues. And that's something that working as an MDT, as a radiographer, we really have to be aware of, because we work with other professions who aren't as skilled when they come to us in radiation protection. So obviously it's our bread and butter, isn't it, Alison? We're all through uni and we learn everything about radiation protection. We know how to look after each other. And as the radiographers working in a room, that's very much our responsibility. So we work with our nursing team when they first start out, and they do radiation protection competencies and learn about radiation protection and understand it more, and things like your time distance shielding principles. The further they can be away from the radiation dose, the less they can be involved in procedures, and if they can put something between them and the radiation source. It's about that teaching part. And even our consultant radiologists, although they've gone through their training process, we have registrars, we have people in training programs. So it's a sort of constant learning process and teaching process for our diagnostic radiographers, so that they can educate everyone working in those rooms. And with it being a theatre as well, we also welcome colleagues from up in theatres. So we do hybrid cases. So things like those EVARs and TVARs and FEVARs, we do hybrid joint theatre cases. So our interventional room, both of our interventional rooms are to theatre standards. So they have the right air turnover, they have the theatre lights and all that kind of good stuff that the surgeons require in order to do their procedures. So we welcome them down too. So we have anaesthetists, we have ODPs, and we have theatre nurses, sort of the full theatre scrub team. And then we have the surgeons as well, and they'll come and do the joint cases with us. So we have to welcome them and make sure that they're wearing all of their radiation protection stuff as well. So Heidi, I don't know if when you started, you've obviously come from an A&E background, but also done a little bit of interventional stuff before. But compared to wider nursing, how did you find coming into radiology and understanding all that radiation stuff that we go on about all the time?
It's a bit daunting to go into a room where there's a big x-ray machine. You've never seen it before. You get told to put on the leads, they're really heavy, and then you get told to stand as far away as possible. So it's a little bit scary to think, is this very risky? But actually, when you're educated on it and the radiographers are really good at teaching about it, you kind of get to a point where it just becomes routine. Sometimes when you're concentrating on your scrub trolley, you kind of forget what you're doing, and the radiographers will remind you to step away from the x-ray. And I think that's really nice that we're all looking out for each other.
Yeah, it really is like that. It's very much an MDT element. So I know I've alluded to this all the way through this podcast, but we really do work together. So it is that multi-profession team, all working together in the best interest of the patient. And patients can come from absolutely all over. So as I've kind of alluded to, our bread and butter stuff is very much the peripheral vascular disease patients. So they're the ones with the blocked arteries in their legs. But we also see patients from across the hospital. So a lot of our work can be cancer. So we do quite a lot of palliative procedures for cancer patients. So, for example, our Hickman line insertions are mostly for chemotherapy patients. We do pleurex drains, so for patients who have ascites in their abdomen or chest, we can put permanent drains in to drain that long term. For patients who have masses in their abdomen that might be blocking the colon, we can put a colonic stent in order to give them some palliative relief in order for things to carry on passing through beyond that blockage. We assist endoscopy quite often, so if they can't do procedures, for example, NG tube or NJ tube insertions or esophageal stent, we might work with them and help them with radiological guidance. So sometimes they come to us and they bring their endoscopy stacks along with them for things like a colonic stent. We do nephrostomies as well, so they're often cancer patients. So patients who can no longer use their urology system, put a nephrostomy in for an external drain. Those patients that we put nephrostomies in, we then see them incredibly regularly going forwards, because the nephrostomy drains need to be changed on a regular basis, otherwise they get blocked up. So we have an advanced nurse practitioner who does the nephrostomy drain changes in our interventional service. We see patients on a major trauma basis as well. So as I alluded to before, bleeding. So us having a 24/7 interventional radiology on-call service is actually part of the Trust's major trauma status. So if we can't provide that, then we can't have a major trauma status on this site. And that's because patients who come in bleeding internally that we can't necessarily get to or can't compress, we will see them in interventional radiology. So they'll come pretty much A&E, CT, straight to interventional radiology theatres, and we will treat them. So we will go to where we think the bleed is based on the CT scan. And to be honest, we can do all kinds of fancy stuff with our X-ray machines. So the interventional radiology machines made by Siemens, it's actually one of those robots that build cars with an X-ray machine on the end of it. So it's like one of those big robot arms. We can load the CT scan into it, and it can then bring up from the CT imaging like a little road map that will take us exactly to where we think the bleed is. So when we put contrast into the CT scan, it gives us a little road map of all the blood vessels. We can then load that up into the X-ray machine, and the X-ray machine knows from the CT scan where that is based on the patient. So it's really fancy stuff that we can do, and that really helps us to treat things quicker. So we can go from that CT scan straight to the patient being on the table, straight to where we know the bleed is, put the contrast in so we exactly replicate that image, and then we go, right, that's what's bleeding. So then we navigate our little wires and catheters straight to the point of it, and then we what's called embolize it. So we can put little microcoils in, we can put bigger coils in, we can put vascular plugs in, and they're basically bits of metal that look a bit like a nest, and they will then encourage the blood to clot, and that will then what's called embolize that artery. So it stops the bleeding, so there's no more bleeding happening anymore. Some of our patients might come straight to A&E with things, I know it's not more serious than internal bleeding because that is bad, but we can have more serious things. So it could be they have a ruptured aneurysm. So obviously I spoke before about EVARs and abdominal aortic aneurysms. So basically a big sac, which was your aorta, has ballooned up and it might rupture. So sometimes we don't pick those patients up on ultrasound or CT before we get to a threshold where we need to intervene. So it could be that those patients actually come in ruptured. Something like 98% of patients who need an aortic aneurysm repair have that done endovascularly, so with us in interventional radiology. So very few of them go to theatre in this trust. It does happen elsewhere, and we recently did some work with the Kerr team, and other areas do have a high proportion of intervening surgically, but we tend to do ours endovascularly because we're really good at it and we do it all the time, and we have really high positive results as well, so we know that we're doing it really well, so our outcomes are good. So we see those patients, but sometimes it can be traumatic.
And we're going to come to the end of the podcast because it's absolutely fantastic hearing all the information and everything. I mean, I could listen to you for hours and hours and hours. And I think people don't always see or understand what's going on in the background and that MDT working with the radiographers and the nurses. So just quickly before we finish the podcast, can I just go around each of you and just say, what's your favourite thing about your job? And then we'll come to a close and we might get you back for another podcast to talk a bit more because it's really interesting.
Yeah, I've about 100 questions.
Yeah, I think we could do another quick Q&A podcast at the end. So does each one of you just want to quickly say what's the best thing about your job, and then we'll come to a close?
Mine's definitely multidisciplinary working. It's working together as a team.
Mine as well, but my favourite part. But my other favourite part is how patient-centred we are. We meet our patients, from elective patients, from the telephone pre-assessments we do. We care for them in the day unit, and then we can care for them one-to-one in the interventional rooms. It's a time when they're vulnerable, they need a lot of care, they're nervous, they've got a lot going on, and then we can care for them afterwards. And we see lots of our patients repeatedly as well, so you build up that lovely rapport with them, and it's a real therapeutic relationship you develop with them. Very special.
I think for me, it's the job satisfaction that you get from all working as a team and knowing that you've given that patient a good experience in the department, knowing that you've made it better.
Well, you do a fantastic job. And I just want to say a big, big thank you for being part of the podcast. I know it's not easy being part of a podcast for the first time, but we'll probably get you back in the future because you're really interesting and it's really good to hear what you've got to say. Kathryn, how's your experience been of co-hosting?
Yeah, well, I was pretty much speechless because I was just listening so intently. And I certainly have learned a lot today just about your service. As I say, I do have 100 questions, but maybe we could bring that back to the next one. But I don't know, I'm just going to ask this anyway. I'd love to know because it does sound such a technical role, like what training have you all gone through to now be in the roles that you're in? Like you mentioned there, you're all advanced practitioners. So really interested to understand. It'd be really good then for people who are listening to this too, if they're suddenly inspired to maybe explore this as a potential career option. So I guess just what training have you all done to be in the roles that you're in?
So it does vary. So some of our people report, and then we have uni courses, things like that. Some of the trainings in-house does very much depend on the role. In order to be an interventional radiographer, or to be an interventional radiology nurse, it's all just in-house training. So that is, although it's a specialist role, you come to us and then we go through a training program, and we're well experienced there. We go through it a lot. So that is our training program. It's in-house.
Okay, great. Thanks, Colin.
Right. Well, thank you very much. Enjoy the rest of your day and take care of each other and yourself.
Thank you.
Bye. Bye.
Cheers.
Thank you for joining us. Till next time, you've been listening to T's Voices.